I want to thank you for the invitation. It's very nice. And I think it's the first time that patients have organized something like a scientific or parascientific meeting to understand the reality of their sickness. I think this could be a new era in which the patient take on themselves the responsibility to understand the problem they have, and maybe not having the right support from the scientific community, they decide to do themselves. I wish you the best. I think you are on the right way, and I hope you will continue like that. My name is Massimo Lombardi. I am nearly 60 in February next year, and I spend all my medical life in eye care. I have been lucky enough to have had very good masters, and maybe the most important in my life has been Professor Sviatoslav Nikolaevich Fyodorov. I think every one of you knows this name. He has been the reinventor of the radial keratotomy, and in fact has been a big scientific man that has created the new way to do surgery in the world. Not only radial keratotomy, but cataract, implantation, and a lot of other things. He was really a genius. And I'm proud to have spent 10 years of my life with him as his personal assistant in the Moscow Eye Research Clinic in Moscow. I want to start giving you information that can help you to understand exactly the anatomy and the physiology and the biomechanics of the cornea. Because if you do not put this information in your head, you will not understand ever completely the proposal you receive about therapy or about any kind of surgery. I will try not to annoy you. I will make some designs that can help you to understand what I'm telling, okay? You can see a cornea, and what you see represented here is on the sclera, the Cocotte ligament. Not many doctors know. What you see there is the Cocotte ligament. Not many doctors know Cocotte ligament. It has been found by a Russian scientist. Cocotte ligament is a very strong fibrous structure of very strong collagen fibers on the scleral part of the cornea. In fact, Cocotte is important because it's like the border or whatever you want. Cornea cannot expand more larger than the Cocotte ring. So it means that you can go in this direction, but you cannot go in this direction. Okay? This is very important because all the system can work only into this ring. Can grow, can enlarge, but cannot come out from the ring. Okay? And is also important also for the Professor Krummeich technique of the ring inside the cornea. That is like to repeat a Cocotte border to a shorter ray of curvature into the cornea. The circular keratotomy. Circularne keratotomy. Maybe you can ask to several doctors what in fact make worsen the cornea, making grow the curvature ray. It's very simple, and nobody has never written till now in any scientific paper. Is the intraocular pressure. Simply the intraocular pressure. The intraocular pressure push along the curvature of the cornea but in fact will push more easily where the cornea is more thin. And the cornea is more thin in the center and paracentral part of itself. So anytime that you have a heart pulse, you have in fact through the central arteria of the retina, you have a push forward of the cornea. Anytime you have the heart, one pulse, this pulse will be transmitted through the central arteria of the retina to the cornea. So every minute, every hour of your life. So it is a very small push, but it is a continuous push. Now, on a normal cornea, this push has been calculated by nature. So it doesn't make any trouble to any cornea. In fact, people that has severe glaucoma can reach 70 millimeter of hydrargyrium, of mercurium, pressure of the eye. And the cornea still maintain its conformation. On the contrary, a keratoconus eye is enough 18, 16 millimeter of hydrargyrium, in Latin is hydrargyrium, to modify slowly, continuously the curvature of the cornea. What is changed in the point that something that nature has prepared to resist to 70 cannot resist to 16? What is changed? The modification is in the structure of the collagen fiber. In fact, the keratoconus is a very particular collagenopathy that has the only place where the collagenopathy exists is into the eye. The cornea, the whole cornea, is done by layers of collagen one over the other. Okay? So, for the colleagues that believe that the cornea is a genetic sickness, the keratoconus in the cornea, and we agree that is a collagenopathy, then I want to ask why is a collagenopathy only in the cornea and not in the whole body like lupus erythematosus systemicus or arthritis rheumatoidis and so on. This must be very clear for you. Collagen is all over our body. We are done for a large part of collagen fibers in the whole body, not only the cornea. So now what happened to the collagen fiber? The collagen fiber is like a spring. Collagen fiber is very similar in the ultrastructure to this spring. Now, something will break the bridges that are along the spiral of the spring. So the spring becomes loose, very elastic, no more resistant to the stretching. It's very important that if you don't understand one point, whoever, you have not to have any complex, please, and raise your hand and tell, I have not understood. Please, okay? So, the spring becomes loose and the cornea becomes weak. So, at this point, is no more a normal structure. And the simple, normal, ophthalmic eye pressure can modify the curvature. In fact, we have machinery that can show that the first modification of a cornea is an inside modification of the inside layer, the Descemet and endothelium membrane layer. They are the first to be modified in this situation. The Descemet membrane is a very strong membrane that supports